Hi, I'm Morgan Anderson, outpatient therapist here at Laureate. I'm so happy that you guys are here joining us. I am trained in EMDR, so do that in both outpatient, and then we'll meet with ladies, residents who are inpatient, who have a history of trauma, to do some collaborative work together so that they can work on both their eating disorder and trauma while they're here. So it's been a really neat opportunity to see what that looks like both inpatient and outpatient. So today we're going to do the webinar on an introductory approach to integrating EMDR with eating disorder treatment, both in the inpatient and outpatient settings. So today's just going to be really great broad information on what EMDR is, what the research says about it with eating disorders, and then a few practical tips for you to take home with you, whether you're trained in EMDR or not, that I have found to be really helpful. So we're just going to dive on in. So the objectives are going to be what EMDR is and isn't. We're going to define the AIP model, which is what EMDR is based off of, how it assists in recovery, and then, like I said, some applications for you to take home. So what is EMDR? First of all, EMDR is evidence-based. As the APA says, it has the same status as CBT for effective treatment for reducing symptoms of PTSD. One of the 4 therapies given the highest level of evidence for PTSD. So really just evidence-based, helpful stuff. So before we get into the presentation, I want for everybody to, wherever you are, to kind of take an inventory of what's around you. I want for you to pay attention to whether it's your office or you're watching it in from your house or wherever you might be, what in your general area makes you feel secure right now? So a lot of times it's not possible to feel 100% secure. I use the example of, say, people are at war and they have guards lining. That makes the area more safe. The guards are lining the fort. But there's still a war going on, but they're able to do that to increase the sense of safety, increase the security around them. So for you, what are some of those things in your immediate environment? Okay, so for me, you know, it's interesting how in my office I work through trauma with people. I talk about really deep stuff, yet whenever I go into my office every day, it doesn't feel like that energy is lingering there. I walk in and it feels secure, it feels good, it feels like a place I want to be. So right now, you know, one of those things, I'm not in my office right now, but one of those things I have in my current environment is this water. Having this water here, knowing I can take a drink of water when I need some water makes me feel secure. It makes me feel more at ease. So for you, what are some of the things that you have done? So notice around you, have pillows around you, maybe blankets. For me, I have a salt lamp in my office, makes it feel great. So I want for you to just notice some of the things that you have that you did to make your place secure. And we're going to put our hands like this, like a butterfly, put them up to our chest. And as you just notice what in your current environment makes you feel secure, I want you to start tapping. And I want you to tap that in as you notice the things that you've done. Good. Now I want you to take a deep breath. Good. So I want you to just notice for yourself on a scale of 0 to 10, 0 being not secure at all, 10 being the most secure you could ever imagine feeling in your whole entire life. On that scale, what are you feeling right now? Okay, so if it's on that lower end of the scale, what practical things can you do to make your environment feel more secure? Maybe you're at home and the door's open and the kids are playing in the hall. Maybe all you need to do is shut that door, you know, and make your place, you know, more just for you. Maybe it's you need to get up real quick before we start this presentation. Go get a blanket, put it around you, get kind of cozy. And then I want to ask also, what makes you feel secure watching this virtual presentation? Is it that you know Laureate and you're comfortable there? Is it that you are real tech savvy and so you feel secure that, okay, I can handle it if my volume doesn't work, I can do these things, and just notice some of those things and tap those things in as well. Okay, so what that was, just setting up at the beginning of this presentation, is called securing your place. And that is an EMDR a skill that we use, and that's something that you can take with you. So setting the stage, whether it's the before therapy session, whenever your client first comes in, asking them these questions, especially virtual, what's going on around you right now? Because a lot of times you can only see this part of my room. You don't know what all is going on around me. So these are just really great questions to ask. Is there something that you're not seeing that maybe is making your client feel unsafe in their current environment? So now I'm going to just dive into what is EMDR. So it's this integration of visual images connected to their trauma. So what picture are you seeing? I'm going to use the example of being held up at gunpoint. That image of the person standing there, what is the worst part of that? Is it them getting into their car and the person coming up to them, the negative belief they have about themselves because of that trauma? So in that example, it makes sense. The negative belief I developed is I'm not safe. But depending on their history, with eating disorders, a lot of times there's attachment issues. And so the belief that they might have isn't just I'm not safe, but I don't matter, that this person would rob me. I obviously am, or I'm worthless, that this person feels they can take from me. And so really individualized to the person, you might be surprised what some of those negative beliefs attached to it can be. And then the related emotions. So when I think of that, I feel distressed, I feel anxious, I feel worried, I feel sad, I feel defeated, whatever that may be. And then body sensation. So once you put those three things together, that image, the belief, the emotions, where in your body do you feel it whenever you think about that picture, that image? And then we start the processing. So the next part is the bilateral stimulation. So typically what that is your left side of your brain starts with an L, or left starts with an L, logic starts with an L, and then the other side of the brain is emotion. So the bilateral stimulation is, as I had you do that tapping in that example earlier, that's that bilateral stimulation, getting both sides of the brain going. That can be tapping, that can be eye movement, which it was named after, or it can be using buzzers in your hands, lots of different options these days. And then there are 8 phases. So I'll walk you through these phases. These are important. So bear with me because I'll refer back to them throughout the presentation. So that first phase, the target planning. So what that is taking a history of what are your goals for EMDR? Is it, I want to not have flashbacks. I want to be able to have better body image. I want to feel comfortable in my own skin. What do you hope to get out of this process? Then the preparation. So that is building the secure place. That's doing what we did, securing your place. And really what my job is, the preparation is so important because this phase allows people to help stay in their window of tolerance during EMDR and learn how to stay in their window of tolerance outside of the session as well. And as the clinician, my job is to help them stay in their window of tolerance during the session so that they can process through them emotions, because when they get above their window of tolerance, they're panicking, they're distressed, they're not going to be able to do the work. If they go so far above it that they go to hypoarousal, they're under their window of tolerance, they're numb, they're dissociated, they're not able to do the work. So my job is to help them stay in that window of tolerance. My job is also to help keep the process moving if they get to a place where they feel stuck with certain questions that I ask, which I'll touch more on later. And so once we go through what's called the secure place, some of the things that we did, that example I did earlier, we got to access and activate. So we bring up the emotions of the trauma right there in the session by asking them a series of questions, asking them to tell us the worst part of that event, what they're feeling, what's that negative belief they have. And then the fourth phase, desensitization, is probably what you think of when you think of EMDR. It's the part where you're actually processing through it. So it's helping them. That's where the tapping comes in. So I say, okay, picture all these feelings, the emotions, the image, the body sensations, and now move your eyes or do whatever the bilateral stimulation is going to be. And then we work through that and we pause and say, okay, what do you notice? And just letting them process it through their own. Once that goes from their distress being on a scale of 1 to 10, whatever it is starting out, all the way to a 0, we then go to the 5th stage, which is the installation of installating the new belief they want to work towards. So if the belief is I'm not safe, what do you want to believe as you think about that trauma? I want to believe I am safe, or I want to believe I am worthy. And so we start to build that back up with the bilateral stimulation. Then we do a body scan. Okay, anywhere else you're holding on to it in your body. Close the session. You know, we might say, okay, imagine a place where you feel really safe. Imagine a place you feel really secure. To help them before they leave the session to kind of decompress before they walk out after bringing up all of that stuff. And then reevaluation is the 8th phase, which happens in the next session. Any dreams you noticed, anything that came up for you, any processing that continued, and just checking in about that. Here's a really great video where Jamil, who is a super great advocate in body positivity, body acceptance. She talks about her experiences in EMDR. I'm not going to get in that today, but feel free to check out this video. It's very great. Okay, so this is just another visual image of what EMDR is. Evidence-based, 8 phases, helps metabolize those unresolved memories that get stuck in the brain through the bilateral stimulation. The D, the dual tension stimulus, that means they're doing something where their thoughts are in the past, thinking out the trauma, but doing something in the present, which is the bilateral stimulation. Whether it's they're following my fingers, they're doing the tapping, their attention is in 2 places at once, both there in the room and 1 foot kind of in the past, which helps that sense of safety, which keeps them in their window of tolerance. And then reprocess, resolve trauma, build resilience, and reclaim wholeness and inherent worth. So it's great stuff. What is EMDR not? So EMDR does not necessarily have to be a detailed description of the event. So we can just say, think about the trauma and do it that way without them ever actually saying a word about their trauma. So depending on their window of tolerance, if it gets to, they're starting to get out of their window of tolerance, we might go back to just thinking about the trauma instead of having them talk about it. It's not directly challenging beliefs. So I'm not saying your beliefs that you're worthless is wrong. I'm just helping them work through it and then build up that belief of I am worth it, I am worthwhile, which I found really helpful with eating disorders, because a lot of times what I find is women here who have struggled with their eating disorders, whenever you challenge that belief of I'm worthless or I'm not enough, they want to argue, they want to defend why they believe that. And then that actually ends up strengthening that negative belief. And so whenever you can kind of go with their momentum and help them work through it rather than directly challenging it, they're able to do some of that work on their own and not get defensive, not defend, and almost protect these negative beliefs that they're holding on to that they see as their identity. It's not extended exposure where they have to keep bringing it up over and over again. It's really considered short-term therapy. And then there's not necessarily homework, which there can be. I feel it works well with DBT. It works well with internal family systems, but there doesn't have to be homework. So I'm going to touch on adaptive information processing. So this is the theory that EMDR is based on. So I'm going to use the example of a Word document on the computer. So, or even like this presentation that I was working on, you start with a blank sheet of paper. You put, maybe you're doing a research, maybe you're writing an article. So you start typing, and that is the raw information. You get to a good stopping point for the day. That's, while you're working on it, imagine that as your working memory in your brain. You save it. Okay, it goes back to your hippocampus or the hard drive on the computer. The next day comes, you're ready to work on it again. So you pull it out of the hippocampus or the hard drive back to your working memory, add to it. save, and it goes back, and you do that until, might take a week or however long until you're done with the paper. That is how you build an adaptive neural network. So, for example, I have a childhood experience where I'm really loved and valued. I feel that, I save that on my long-term memory. Another experience comes up. Maybe I get a boyfriend who's really great. I feel loved and valued. That updates, and then I save that to my long-term memory. And then growing up, I make best friends. I feel very loved and valued. So it kind of builds this adaptive neural network in my brain with that belief I'm loved. So that's where it starts. So where does it go whenever trauma happens? How does trauma interrupt that cycle? Well, I'm here to tell you. So traumatic events are stored maladaptively in the brain. They aren't so easy like that Word document example I was giving. They, due to the emotions, beliefs, and body sensations associated with them, that adaptive updating is prevented. So say this trauma comes where I'm feeling not loved, maybe something really traumatic happens. And another example comes where I'm treated with love. That trauma kind of keeps that new event from getting from the working memory, from the prefrontal cortex to the hippocampus. So it can't be saved there. So for an example, a client who had experiences where they were told they were worthless over and over again, or maybe they just weren't treated with love, because research is showing with eating disorders, insecure attachment can happen in 70 to 100% of clients. And so they have these experiences where they're not feeling worthy. And then an example comes where at work they're told, you're great, you're wonderful, we value you so much, but they refuse to believe that they struggle with this imposter syndrome, that I'm not good enough, I just know it, even though they're told multiple times, because that trauma interrupted them from being able to get that validation to their hippocampus. So how can EMDR help with this process? Well, that's where the bilateral stimulation comes in. That's where that process really helps them integrate their negative experiences with the positive ones to help them get to a place where they can say, okay, yes, this bad thing did happen. However, it's not defining me and my sense of who I am. So this is just an example of that. The study that I found by Kazan, that the left hemisphere is associated with self-control. And remember, that's the logic side, whereas the right hemisphere is associated with self-regulation. So self-control is, I have one goal, I have to pursue it at all costs, no matter what. With eating disorders, that's often weight loss or controlling food, whereas self-regulation is more, I have a goal, but it's more democratic. I have other things, maybe I want to get an A in school, but I also want to spend time with friends, and I also need to nourish my body. And so it's pursuing a goal, but not forgetting about all the other goals. And so what they found is that there might be a right hemisphere deficit in anorexia nervosa patients, that self-regulation part. And so the bilateral stimulation, that back and forth, can help increase right hemisphere activation so that that self-regulation part can increase. And it's shown that this can help with body image. So this is, I'm going to talk a little bit about the EMDR Eating Disorder Protocol, that it's really based on attachment-related issues. So a lack of safety with a caregiver, dysfunctional control strategies because of that lack of safety, and maladaptive coping skills can lead to this need for perceived control or control compensation. I'm overly controlling my grades. A lot of times we'll see a lot of perfectionist behaviors, or I'm over controlling my weight loss, or my body size, my body shape. to really compensate for a lack of control they actually feel like that they have. And so EMDR leads to this resolution of the unresolved trauma. And this trauma is more attachment-based, which I consider attachment-based trauma to be little t trauma, which is more a series of wounds. It can be neglect. It can be any time that we've felt helpless or hopeless, a time we felt out of control, a time we felt abandoned. Those kind of little t. Big T trauma is the times that anybody would consider trauma, you know, an assault, a big car accident, that sort of thing. So EMDR helps target some of those little t traumas that the person might not even consider to be a trauma because it was just their normal. And so whenever they can work through that, it changes their representation of early attachment relationships with their caregivers. So being able to look at their parents not as these people who greatly wounded me, but maybe being able to see like my parents are people with their own trauma who were doing what they knew how to do, and maybe it wasn't good and it still wounded me. But I can hold both, that they struggled in their own way too, and that they hurt me. And so kind of being able to find that healthier view of that relationship, and then decreases their negative beliefs about self-worth. And so EMDR really helps with restoring some of those childhood traumatic memories that really impact the brain. So what areas do we target? I'm gonna take a drink of my water because it builds my security, having that here, as I talked about earlier. So areas to target: we can target negative body image in EMDR with the most recent, the earliest, and the worst body image experience. I remember having a client who said, I remember being 3 years old and looking in the mirror in the dressing room thinking I was fat. And so that's something that we can target of, okay, where did they learn to believe that? What is that belief behind that feeling of I'm fat? Is it I'm not good enough? I'm less than, whatever? What is that? We can target food-related trauma or ARFID. So I have a client who has celiac, and before that was diagnosed, she was sick all the time with food, and now she has a big aversion to a lot of foods that made her sick. So we're targeting that in our work in EMDR. Or you can target non-food related single event traumas. So that could be a big trauma, but you can't necessarily say that trauma is the reason the eating disorder developed. So that trauma might be resolved. That doesn't necessarily mean the eating disorder will be resolved just because that trauma is. Whereas the food traumas and the body image are going to more directly impact eating disorder recovery as well. So here are just some special considerations that I have just from my experience of what I found to be helpful. I found that validating the part of the client that needs control is very important. So in EMDR, there's no good or bad part. So even their eating disorder is a part of them that needs control. Now, I don't know about you, but I know I need a sense of control in my life. Now, if that part that needs control turns into that control compensation where I'm engaging in eating disorder behaviors, that's problematic. But at the core of it, it's just a part of me that wants to feel safe. So validating that is so important, and saying, you know, I understand you need control. What's maybe a new job that we can find for that part of that you that needs control, rather than hyper controlling your food or your exercise or your perfectionism? What's a new way you can build control? Maybe you can build control by setting boundaries. Maybe you can build control by, learning how to say no or walk away from a situation, and building control in that way, in a way where it's actually keeping them safe and not actually hurting them worse, which a lot of times eating disorder builds up that, okay, I have control, but then actually makes them less safe because of health complications, or it pushes people away, and so then they're more alone, and then it kind of, they're using their eating disorder to cope with the issues caused by their eating disorder. And so what are some good ways that we can build that sense of control in your life? I found that a lot of times there's a fear of doing it wrong. And that is kind of to be expected with our clients who are super perfectionistic. They want to know that they're doing it right. And so really validating, be sure, say, there's no right or wrong. This is just your experience, your process. For those of you who are trained in EMDR, this is going to make more sense, but starting with, I found that when I start with EMD, opposed to doing the full EMDR, they're more likely to get into it and have less anxiety about doing it wrong. So those of you who aren't trained in EMDR, what that means is basically having them think about the trauma, one specific event, and rating that on a scale of 1 to 10, the distress, without actually talking about the trauma and getting really deep into it. And I found once they feel comfortable with that, I can kind of expand it and get more into the EMDR where they are processing the trauma out loud in the session and that sort of thing. So with that, I found, whenever they believe it's going to work, it's going to be more effective, than if they are decided this is weird, it's not going to work. And then I also found it's very important to avoid evidence-based cognitive positive cognition. So as I spoke about earlier, in those earlier stages, in stage 1 and 2, we really define what is that negative belief you have attached to your trauma. Maybe it's I'm not good enough. So we want to find a positive belief to replace that with. And I found beliefs like I'm enough can be dangerous if not handled with care, because as we talk about examples in their life where they felt that they were enough, a lot of times they'll go to, well, when I achieved this, I was enough. And when I, accomplished this, I was enough. And so I think that really can actually reinforce the part of them that believes I have to be perfect, I have to have control. And so what I found is saying, instead of I'm enough, saying I'm okay regardless, or I'm enough regardless. So looking for times in their life where they felt I'm good enough regardless if I did good or not. Times where maybe they just saw themselves as a kid playing on the playground, having a good time, where it wasn't about achieving anything or not, but just there was a time in my life where I just felt like I was enough and I was okay, and it had nothing to do with what they achieved or accomplished. And that's during the target sequence of phase 1, where we go through a list of this is the negative belief, what are the memories associated with that, here's the positive belief, what are the memories associated with that. So really avoiding those achievement-based positive belief examples. So when is EMDR appropriate? So I have found that when they're following their meal plan, or at least showing a willingness to follow a meal plan, they're doing intuitive eating, that it's helpful. If they are weight restored and they have a desire to address the trauma, that's all whenever it is a good time to do it. Inpatient can be a little bit different because there is more control to make sure they continue eating, but outpatient, there is that risk of my eating disorder has historically been a coping skill for my trauma. So wanting to make sure that they are weight restored. I've had women come inpatient who said they did eating disorder treatment before they came in and they don't remember anything from it just because they weren't in a good place. Their minds weren't nourished to be able to do some of that work. So barriers that impact effectiveness, kind of the opposite, malnourishment, eating disorder as a coping skill. And then telehealth isn't necessarily a barrier, but is something where you have to really talk about, like, okay, here's the risks. What are we going to do if the computer dies in the middle of session, that sort of thing? What are we going to do if technology fails us? And so having kind of a conversation of risks and benefits before just jumping into it. Also making sure there is an awareness of their environment. As a practitioner, you need to be aware of, okay, what's going on around you that might be making you feel safe or unsafe. So here are some examples of what you can do, as we talked about that secure your place earlier. Another thing for clients is having them figure out who's a protective, a nurturing, and a wise figure in their life. So maybe that protective figure is Wonder Woman, and have them picture Wonder Woman being there with them, and then tapping that in, what it feels like to know that they can call on that person if they're feeling anxious. Or a nurturing figure, maybe that's a teacher that they had, or a wise figure, a grandparent or something, and they can tap that in. The next is identifying going with negative core beliefs instead of challenging them. So having them explore their negative beliefs, and then what are the positive, where's the evidence of the positive beliefs in their life. And saying, I always use the example, when I bought a new car, I started seeing those cars everywhere. There's not really more of them, I'm just more aware of them. And so I'm not challenging their negative belief, but I'm saying just practice being aware of the evidence of this positive belief in your mind, because you've been so aware of the negative belief and all the evidence that supports that. Target sequencing is like a timeline I said earlier, only you're timelining examples that support that negative and positive belief in their life. And so that's something that can be really helpful. And then the interweaves, those are questions that kind of ask to keep information going, to keep them processing. So questions like, if they're stuck, asking like, okay, what would a younger part of yourself do in this situation? Or what does that younger part of you need? And there's lots of good information on interweave. So that is the presentation. I'm excited to answer any questions that you might have. And thank you so much for being here. Here are some videos that you can look up and get some more information. So thank you. Stop share. Oh, is it recording? I hope I actually recorded all that.